Hello friends, welcome to another session of biochemistry, and in this session we will try to finish off the vitamins first, and tomorrow we'll start a fresh session on the molecular biology. All right, so let's complete the vitamins topic today and go on to molecular biology from tomorrow. All right, all right. So we're starting with the vitamins. Just mark your attendance so that I know all of you have come back. Send me a hi so that I know you can see it. Just write the comments whether video, audio, and the screen are clearly visible or not. Okay, so we are starting with the session on vitamins. We are starting with the session on vitamins. Okay, first and foremost, what are vitamins? What are vitamins? You should know what are vitamins. So very briefly, they are small organic molecules which facilitate metabolic pathways. Small organic molecules which facilitate metabolic pathway, and secondly, they don't provide energy. They don't provide energy. If you look at the old nomenclature, initially they were thought to be minerals, and they were called vital minerals. They were labeled as vital minerals. Later, when they were separated and characterized, it was realized that they are not actually minerals. They are not actually minerals, and but the name vitamins persist. They are small organic molecules which facilitate the metabolic pathways. They don't provide any energy. They don't provide any energy. Okay, let us quickly take a look at the different types of vitamins. If you talk about the different type of vitamins, we have the lipid soluble vitamins, and in the lipid soluble we have the vitamin A, vitamin D, vitamin E, and vitamin K. You know, vitamin A, D, E, and K. And then we have the water soluble vitamins, the vitamin B complex, and the vitamin C. So these are the lipid soluble and the water soluble vitamins. The biochemical names for the different vitamins: the vitamin A, the three active forms are the retinol, retinal, and retinoic acid. Remember, beta carotene is the precursor. It is not vitamin A, it is the precursor of vitamin A, which is available in the diet. Vitamin C, known as the ascorbic acid. Vitamin D, known as the cholecalciferol. Vitamin D, known as the cholecalciferol. The active form is the 125 dihydroxycholecalciferol, but in the blood, the level is measured for the 25 hydroxycholecalciferol, because the 125 has a very short half-life. It has a very short half-life. So normally, to determine the level of vitamin D, we measure the 25 hydroxycholecalciferol form of vitamin D. Then we have vitamin E. Vitamin E is also known as the tocopherol, and vitamin K. Vitamin K is known as phyloquinone. Phyloquinone is the one which we get from plants. It is the K1. We also have the menaquinone form. The menaquinone, which is K2, it is produced by conversion of K1 by the gut bacteria. The gut bacteria can convert it to K2. The other bacteria outside the body can also convert the K1 into K2. So K2 can either be in the gut, or it can come in the diet when it is produced by the bacteria. And the synthetic form, which is available commercially, is the menadione K3. It is the menadione K3. It is the water soluble form. The K3 form. Coming to the B complex, in this one we had talked about everything except the B complex. Coming to the B complex, collectively they are known as the anti-stress vitamins. If you are asked to select one, which of the following is the anti-stress vitamin, in that case you can go for the vitamin B1. You can go for vitamin B1. B1 is individually also known as the anti-stress vitamin, but more correctly it is the collective name for the B complex vitamins. What B2 is the riboflavin. Vitamin B2 is the riboflavin. The B3 is niacin. We had seen some of these when we were doing the carbohydrate metabolism. The B5 is the pantothenic acid, and B6 is pyridoxine. B7, also known as vitamin H, is the biotin. B7 or H is biotin. B9 is folic acid. B9 is folic acid, and B12 is cobalamin. The commercially available form is known as the cyanocobalamin. The commercially available form is known as the cyanocobalamin. Otherwise, the normal name is the cobalamin. So B1, B2, B3, B5, B6, B7, B9, and B12 are the different vitamins in the B complex heading. Different vitamins in the B complex heading. Now there is one very important topic: vitamins synthesized in the body. When the question comes about synthesis in the body, you have to read the question very carefully, whether it says in the body or it says by the body. The answers can be different for the two. Reason being, once you look at them, then I'll describe what do you mean by in the body and by the body. The B3, niacin synthesized from tryptophan, we had seen when we are doing the amino acids. So niacin synthesized from tryptophan, 60 milligram tryptophan required to synthesize 1 milligram niacin. This is synthesized by the body. Obviously it is in the body, but more accurately it is synthesized by the body. B5, pantothenic acid. It is synthesized by the colonic bacteria, not by the body. The body does not synthesize, but the colonic bacteria is making the vitamin B5 inside the body. So synthesis occurs in the body, but not by the body. So you have to read the question carefully, whether it is talking about by the body or in the body. Now, it is very important that if the colonic bacteria is synthesizing some product, there should be receptors, or you can say the transporters, to take up that substance. Otherwise, that substance will go waste. Typically, in the large intestine, mostly the uptake of the electrolytes and the water occurs. The other substances are rarely absorbed. So you need dedicated transporter for that particular substance. Otherwise, it will go to waste. This is applicable and true for B5. We have the sodium dependent multivitamin transporter in the large intestine, which identifies the B5 and takes it up. It identifies the B5 and takes it up. So sodium dependent multivitamin transporter will take up the B5 synthesized in the large intestine by the colonic bacteria. Then we have B7, biotin, again synthesized by the colonic bacteria and by the same transporter, sodium dependent multivitamin transporter. It is taken up in the large intestine. So B5, B7 synthesized in the body but not by the body. They are synthesized in the body but not by the body. B12, synthesized by colonic bacteria, but that part is not absorbed. Remember, B12 absorption occurs in the small intestine, in the ileum only, and that too in the presence of intrinsic factor. If intrinsic factor is not there, the B12 absorption will not occur. The absorption has to occur at the ileum. So although B12 synthesis does occur by the colonic bacteria, it is not absorbed by the body. So most of that synthesis is futile synthesis. Remember, the B12 synthesized in the body but not available to the body. Vitamin D. Vitamin D is synthesized from cholesterol by the body. So this one is by the body. It is synthesized from cholesterol by the body, and after synthesis is activated in the liver and kidney. Even the dietary form which is consumed has to be activated in the first in the liver at position 25 and at position 1 in the kidney. So these are Some of the important vitamins synthesized in the body. The vitamin K2. Vitamin K2 is also synthesized by the colonic bacteria. In this case, a small amount can be absorbed, meaning if you carry out the gut sterilization, there is chances that the individual may suffer from vitamin K deficiency, because some amount of vitamin K is absorbed from the large intestine, although it is not too great, but definitely some amount is absorbed from the large intestine. So vitamin K, that is K2 form, is absorbed from the large intestine. It is synthesized in the body by the colonic bacteria, but not by the body. So by the body we have only two. When the question says which of the following vitamins are synthesized by the body, we have the B3 and vitamin D. All other vitamins are not synthesized by the body, they are synthesized by the colonic gut bacteria, colonic bacteria. Okay. Let's start with vitamin A. So what I'll do, I'll only be giving you the highlights of the vitamins which you need to solve the questions. At some places I'll talk about RDA, but other places I may not talk about RDA, depending on the importance of that particular topic for your exam. Okay. Active form of vitamin A. There are three active forms of vitamin A. We already said the retinol, retinal, and retinoic acid. The pro form is the beta carotene. The pro form is the beta carotene. Here, I'd like to clarify one thing. A large number of books and guides write vitamin A as antioxidant vitamin. Large number of books will write it as antioxidant vitamin. This is not correct. Vitamin A is not an antioxidant vitamin, only the beta carotene is antioxidant. The precursor beta carotene is antioxidant, vitamin A is not antioxidant. Please make note of this. The vitamin A in the body is stored in the I2 cells of liver, stored in the I2 cells of liver. Recommended daily or dietary allowance is 600 microgram per day. It is general allowance for all individuals, the 600 microgram per day. Actions, some of very important actions of vitamin A. The most important, it is part of the walled cycle, the visual cycle known as the walled cycle. It is the part of walled cycle. We'll see this visual cycle in the physiology section. When we do the vision in physiology section, there we'll talk about the walled cycle. We'll also cover this again in the ophthalmology section. It also participates in regulation of gene expression and tissue differentiation. I already told you that beta carotene will act as antioxidant. In large doses, it is teratogenic, so must be avoided in pregnant females. It has to be avoided in pregnant females. Even some skin applications which contain vitamin A are not allowed during pregnancy because they are teratogenic. They can be quickly absorbed from the skin and cross the placenta and cause the teratogenic effects in the fetus. So remember, avoid, rather do not allow use of vitamin A during pregnancy in any significant amount. Better safe than sorry. Or supplementation with vitamin A is to be avoided during pregnancy because it is teratogenic. Teratogenic means it will cause a malformation of the fetus and the embryo. It will cause the malformation of the fetus and the embryo. Then we come to vitamin A deficiency. Vitamin A deficiency is identified worldwide as the most important preventable cause of blindness, particularly in India. It is the most important preventable cause of blindness. So you will read in the community medicine that we have a program for vitamin A supplementation. The details of that program I'll not cover here. In PSM, we'll talk about the details of the vitamin A supplementation program as a counter to the widespread blindness caused due to vitamin A deficiency. The earliest sign of deficiency is loss of sensitivity to green light. The earliest sign of deficiency which has been asked is loss of sensitivity to the green light. After that, we have the impairment to adapt to dim light and then we have the night blindness. Here I'd like to mention one very important thing. Night blindness, as shown in the movies, is not like when the sunset occurs the person cannot see, and when the sunrise happens then only the person can see. Night blindness means the person is unable to see in dim light or low light. In normal light, even at the night in the room, if there is sufficient light, the person can see. The person cannot see in low light settings. Okay, so that is the night blindness. If you provide ambient light, then the person can still see. Prolonged deficiency leads to xerophthalmia, keratination of cornea, and eventually blindness. The detail of how vitamin A is progressing in terms of ophthalmic presentation will obviously be covered in ophthalmology, because it is a very, very important clinical presentation in the ophthalmology section. Vitamin A deficiency also increases susceptibility to infectious diseases. It also increases susceptibility to infectious diseases. The retinol binding protein is considered as a negative acute phase protein. It is considered as a negative acute phase protein. नीचे से उधर तक खोल देना पीछे. Okay. So moving on, vitamin A toxicity is also seen. One is vitamin A deficiency. When adequate vitamin A is not present in the diet, then we have the vitamin A deficiency. But excess consumption of vitamin A will also cause toxicity. The toxicity will be seen in all the lipid soluble vitamins. Why? See, if you have the water soluble vitamins, if there is excess, it can be lost in the urine. Water soluble form will go away in the urine. But if it is a lipid soluble, it starts getting deposited in the body, and that is why for the lipid soluble vitamins we have the presentation of the toxicity. So in case of vitamin A toxicity, please take a quick look at the clinical features. Acha. Please look at the clinical features. First, the CNS. What do you find in the CNS? Headache, nausea, ataxia, anorexia. So the classical features of increased intracranial tension, and we call it the pseudo tumor cerebri. Okay, because it gives the appearance of space occupying lesion, but when you examine, when you do the investigations, we don't find any tumor in the brain, so it is known as the pseudo tumor cerebri. In the liver, the hepatomegaly will be there with histological changes and hyperlipidemia. Remember, vitamin A is stored in the liver in the ito cells. Then in calcium homeostasis, there is thickening of long bones, hypercalcemia, and calcification of the soft tissues. The calcinosis is occurring. The calcification of the soft tissues is seen. The calcification of soft tissues is seen. And in case of skin, we have the excessive dryness, desquamation, and alopecia. Alopecia means hair loss from the head. Hair loss from the head is also seen. So these are the clinical features of vitamin A toxicity. The clinical features of vitamin A toxicity. So that was about vitamin A. Let's do a quick recap. A quick recap. Vitamin A, the active forms are retinol, retinoic acid. The pro form is beta carotene, stored in ito cells of the liver. Recommended daily or dietary allowance is 600 microgram per day. The most important role is as part of the visual cycle. It constitutes the visual pigments in retina. It also has a very important role in regulation of gene expression and the tissue differentiation. I already said beta carotene acts as antioxidant, not the vitamin A, and in large doses it is teratogenic, so must be avoided during pregnancy. Vitamin A deficiency is the most important preventable cause of blindness. Initially, there is decreased sensitivity to green light, followed by impairment to adapt to dim light, and then night blindness. Even then, if there is no correction, then we have the xerophthalmia, the keratinization of cornea, followed by the blindness. In addition, vitamin A deficiency causes increased susceptibility to infectious diseases. It is the negative acute phase protein, meaning during infections or stress conditions, there will be further decrease in synthesis of retinol binding protein. Okay, and then we have the vitamin A toxicity. Then we have the vitamin A toxicity. In vitamin A toxicity, we have the clinical features of pseudotumors cerebri. There is hepatomegaly and histological changes, and calcinosis is seen, thickening of long bones, hypercalcemia is seen, and the skin, the excessive dryness, desquamation, and alopecia are some of the very important findings. Then we come to vitamin D. Vitamin D is very frequently asked, so please pay extra attention to this section. Major source of vitamin D is skin, provided sufficient exposure to sunlight is there. It is a conditional source. If sunlight exposure is there, then the vitamin D can be synthesized by the body, and therefore it is strictly speaking not a vitamin. Strictly speaking, it is not a vitamin. Sometimes it is known as a hormone. Otherwise, dietary source of vitamin D is generally not sufficient. So you'll find that individuals who are not adequately exposed to sun are very frequently vitamin D deficient, and they will need supplementation with vitamin D to bring their levels to an acceptable level. Now, what are the functions of vitamin D? The most important function is regulation of calcium absorption and homeostasis. This is the classical role of vitamin D: regulation of calcium absorption and homeostasis, which is mediated by nucleoreceptors that regulate the gene expression. However, recently, a very important role of vitamin D has been found in regulating cell proliferation and differentiation. Lastly, large number of studies have shown that higher intake reduces risk of insulin resistance, obesity, and metabolic syndrome, as well as it protects from various cancers like the prostate and the colorectal cancer, like the prostate and the colorectal cancer. The active vitamin D is the calcitriol. I'll show you how the active vitamin D is formed. It maintains plasma calcium concentration via one of the three ways. It will increase the intestinal absorption of calcium along with phosphate. It reduces the excretion of calcium but not phosphate. At the level of kidney, it will reabsorb the calcium. The phosphate is allowed to go. So it stimulates the reabsorption in the distal renal tubules. And if required, it will mobilize the bone calcium. If required, it will mobilize the bone calcium. Let's look at how it is synthesized in the skin. Very straightforward process. The dehydrocholesterol under the influence of light is quickly converted to the pre-vitamin D, and after thermal isomerization it gets converted to the cholecalciferol, and that is the vitamin D3. Cholecalciferol is the vitamin D3. It has two hydroxyl groups, so it is the sorry, it's one hydroxyl group, so it is the calciol. It has a single hydroxyl group, and therefore it is known as the calciol. Okay, please note, if there is prolonged exposure to the sunlight, then the cholecalciferol is further converted to a soluble form of the cholesterol form, and it is not available for activation. So it can be automatically isomerized further. Therefore, on prolonged exposure to sunlight, vitamin D toxicity does not occur. Okay, the prolonged exposure to sunlight does not cause vitamin D toxicity because there is spontaneous reconversion of the vitamin D3. Once the vitamin D3 is there, whether it is coming from the skin or it is coming from the diet, it doesn't matter. Once the vitamin D3 is there, then it has to be activated. First, the activation occurs in the liver. First, the activation occurs in the liver, and the enzyme is the 25 hydroxylase. The 25 hydroxylase will attach the hydroxyl group at position at 25. So we get the 25 hydroxy cholecalciferol, also known as calcidiol. Previously we had one alcohol group. In the cholecalciferol we had called it the calciol. Now we have two hydroxyl groups, so we call it the calcidiol. That is the 25 hydroxy cholecalciferol is the calcidiol. And then we have the 1 alpha hydroxylase. We have the 1 alpha hydroxylase. It will act upon the 25 hydroxycholecalciferol and convert it to 125 dihydroxycholecalciferol. Now we have three hydroxyl groups, so it is known as the calcitriol. We don't use the term calcitriol commonly. Reason being, there is another enzyme, the 24 hydroxylase, the 24 hydroxylase, which can also attach the hydroxyl group but at position 24, giving rise to the 25 hydroxycalcidiol, which is also the calcitriol. This form is inactive. This form is inactive. So to avoid confusion, we don't use the term calcitriol. To avoid confusion, we don't use the term calcitriol. Rather, we call it the 125 dihydroxy cholecalciferol. We call it the 125 dihydroxy cholecalciferol. The 125 dihydroxy cholecalciferol can be quickly inactivated by the action of the 25 alpha hydroxylase. So what you get is the calcitetrol. The calcitetrol can also be formed by the conversion of the 24 hydroxy cholecalcidiol by the enzyme 1 alpha hydroxylase. Okay, so inactivation of 125 dihydroxy cholecalciferol by the enzyme 24 alpha hydroxylase, again in the kidney only, So vitamin D first converted to 25 hydroxycholecalciferol and then converted to the active form, which is the 125 dihydroxycholecalciferol. This is the final active form which is acting at the level of the cells and the tissues. Deficiency in children causes rickets, that is poor mineralization of the bone. In adults, it causes the osteomalacia, not the osteoporosis. Some of the guides and books will write osteoporosis, which is wrong. The deficiency of vitamin D will cause osteomalacia, that is demineralization of the bone. It will cause osteomalacia, that is demineralization of the bone. Again, the vitamin D can also cause toxicity, and the causes are commonly dietary, but in some individuals there can be the genetic defect where the inactivating enzyme, the 24 alpha hydroxylase, is not there. So the 125 dihydroxy form will persist in circulation and it will result in toxicity. So calcinosis occurs here also, just like in vitamin A toxicity, and it leads to contraction of blood vessels resulting in high blood pressure. So calcinosis as well as increased blood pressure due to contraction of the blood vessels. So that was vitamin D. Let's do a quick recap for vitamin D. Major source, if sunlight is available, that's skin. If sunlight is not available, generally the dietary sources are poor and individual will have the vitamin D deficiency. Supplementation will be required because it can be synthesized in the body. It is generally not considered a vitamin, rather because of its actions it is known as a hormone. The function, the primary well-defined function is regulation of calcium absorption and homeostasis, and this is mediated by nuclear receptors. So vitamin D is the type 1 hormone. It acts like type 1 hormone. It goes to the nucleus and directly acts via the nuclear receptors. It also has a role in regulating cell proliferation and differentiation. And recently, now large number of studies have shown that higher intake reduce the risk of insulin resistance, obesity, and metabolic syndrome, as well as various cancers like the prostate cancer and the colorectal cancer. The active form of vitamin D, the vitamin D calcitriol, maintains plasma concentration by one of the three ways. It will increase absorption of calcium from the intestine. It will reduce the excretion of calcium by increasing the reabsorption, and it will mobilize the calcium from the bone. So it mobilizes the bone mineral. Synthesis in the skin, first by light, the dehydrocholesterol 7 dehydro 7 dehydrocholesterol by light is converted first to pre-vitamin D, and then by thermal isomerization, by heat it is converted to the cholecalciferol, that is the vitamin D3. Further activation, whether it is coming from the skin or from the diet, first occurs in the liver by the 25 hydroxylase, where we get the 25 hydroxycholecalciferol. I had mentioned that this is the form which is used for estimation of vitamin D levels in the body because of its longer half-life. Subsequently, the 25 hydroxy form is converted to the 125 dihydroxycholecalciferol by the 1 hydroxylase, calcidol 1 hydroxylase, which is there in the kidney. The active form can be inactivated quickly by the action of 24 hydroxylase, which converts the 125 dihydroxycholecalciferol to the calcitetrol. Calcitetrol is the inactive form of vitamin D3. So the half-life of the calcitriol is measured in minutes. About 3 to 5 minutes is the half-life for calcitriol, because it is very quickly inactivated. Very quickly it is inactivated. The vitamin A deficiency in children will cause rickets. The details, the details of rickets in terms of the radio imaging picture, the clinical picture, we'll see in the pediatrics, not here. In adults, it causes the osteomalacia, that is demineralization of bone. Toxicity also occurs just like it was occurring in vitamin A. Primarily, it can be dietary. Lot of extra supplementation of vitamin D has been taken by the individual. Rarely, it can be genetic defect in the degrading or the inactivating enzyme, that is the 24 hydroxylase. It leads to contraction of blood vessels, which causes increase in the blood pressure. And just like vitamin A toxicity, it causes the calcinosis or the calcification of the soft tissues. Then we come to vitamin E. At the outset, I'll tell you that vitamin E functions are not clear cut, and moreover, the deficiency is not well documented. The vitamin E is another lipid soluble vitamin, and it is the antioxidant vitamin in cell membrane. It is the lipid soluble antioxidant vitamin in the cell membrane. There are two types of antioxidant: chain preventing and the chain breaking. So vitamin E is the chain breaking antioxidant. It is the chain breaking antioxidant. It is the free radical trapping antioxidant in cell membrane and plasma lipoprotein. The recycling of vitamin E is done by vitamin C. Once it is oxidized, it can be reduced again by the vitamin C. It has a very important role in cell signaling, and dietary deficiency, I told you, is unknown. It is suggested that deficiency will cause neurological dysfunction. Then we come to vitamin K. Vitamin K is very, very vital for the carboxylation of glutamate residue in a large number of proteins. Okay, so the carboxylation of the glutamate residue gives rise to the gamma carboxyglutamate. The gamma carboxyglutamate is required for activation of a large number of proteins. Okay, so vitamin K will cause the carboxylation of glutamate residue and generate the gamma carboxyglutamate, written as the GLA. The two enzymes involved in this carboxylation of glutamate residues are the vitamin K epoxide reductase, which is warfarin sensitive, and the warfarin insensitive quinone reductase. Warfarin insensitive quinone reductase. So these two vitamins are involved primarily in the metabolism of vitamin K. And if there is deficiency of vitamin K, there will be impaired blood clotting and hemorrhagic disease, because one of the very important proteins which need to be activated by the gamma carboxylation are the clotting factors. 2, 7, 9 and 10 are the clotting factors which require the activation. So like I said, it is required for action of clotting factors 2, 7, 9 and 10, as well as the anti-clotting factors protein C and protein S. The gamma carboxyglutamate chelates the calcium ions, and it permits the binding with the cell membrane. So the gamma carboxyglutamate required here for activation. The prolonged antibiotic therapy will cause the gut sterilization, and it can be one of the minor causes for deficiency of vitamin K. Vitamin K also affects bone health by activating calcium binding protein. Some of the proteins which are activated are osteocalcin and the matrix protein, which contain the gamma carboxyglutamate. In fact, the deficiency of vitamin K is identified by measuring the undercarboxylated osteocalcin in the blood. The undercarboxylated osteocalcin blood levels provide an index of vitamin K status. If this value is high, then vitamin K deficiency is there. If this value is low, then vitamin K deficiency is not there. So undercarboxylated osteocalcin blood levels provide an index for vitamin K status. In addition, in the kidney, the nephrocalcin is also undergoing the carboxylation. So which all proteins? Factor 2, 7, 9 and 10. Protein C and S. The bone osteocalcin and the matrix GLA protein and the nephrocalcin. These are some of the important proteins which need to undergo gamma carboxylation under the influence of the vitamin K. So that was the lipid soluble vitamins. Quickly, I'll do the recap for vitamin K. The vitamin K, we have already said, it can be of three types: vitamin K1, K2, K3 phyloquinone, and the K2 form, and the K3 form, which is the menadione, the water soluble form. The vitamin K is primarily required for carboxylation of glutamate residue in the post-synthetic modification of large number of proteins. It results in formation of the gamma carboxyglutamate. The two enzymes required in vitamin K metabolism are the vitamin K epoxide reductase, which is warfarin sensitive. This epoxide reductase question has been asked twice in the NEET exam. And the warfarin sensitive quinone reductase. It helps to bypass the warfarin block. If there is deficiency, there will be impaired blood clotting and the hemorrhagic disease. Vitamin K is required for activation of large number of proteins. These are factor 2, 7, 9 and 10, as well as protein C and S. The gamma carboxyglutamate amino acid will chelate the calcium ion and thereby permits binding to the membrane so that the clot can adhere. Prolonged antibiotic therapy can be a minor cause for deficiency, and the vitamin K resulting carboxylation also affects bone health because it activates the osteocalcin and the matrix GLA protein. Under carboxylated osteocalcin blood level is used to determine the vitamin K levels. The nephrocalcin in the kidney is also undergoing the carboxylation, the gamma carboxylation by the vitamin K. And now we come to the water soluble vitamins, starting with thiamine, that is vitamin B1. Vitamin B1 is unique among all the vitamins, vitamin B1 as well as vitamin B2. Vitamin B1 and vitamin B2. Okay, so why are they unique? Because their RDA, the recommended dietary or the daily allowance, is not dependent on the body weight. Whenever we talk about RDA, we talk in terms of body weight. But for the vitamin B1 and vitamin B2, the RDA is 0.5 milligram per 1000 kilocalorie of energy intake. It is per 1000 kilocalorie for of energy intake. Okay, thiamine levels are monitored by the erythrocyte transketolase. The thiamine levels are monitored by the erythrocyte transketolase. Vitamin K, we had said, by the osteocalcin under carboxylated osteocalcin level, but vitamin B1 by measuring the activity of erythrocyte transketolase before giving the supplement of vitamin B1. Functions, very important functions. Most of this we have already enumerated when we are doing the carbon metabolism. The pyruvate dehydrogenase requires the thiamine pyrophosphate. The alpha ketoglutarate dehydrogenase in the Krebs cycle requires the thiamine pyrophosphate. The trans ketolase in HMP shunt requires the thiamine pyrophosphate, and the branch chain keto acid dehydrogenase in the branch chain amino acid metabolism also requires the thiamine pyrophosphate. In addition, the thiamine is required for acetylcholine formation, and it helps to regulate the chloride channel in nerve conduction. It helps to regulate the chloride channel in nerve conduction. So thiamine is very important for energy metabolism. Thiamine is very important for energy metabolism, and deficiency results in two common disorders, that is the beriberi and the Wernicke's encephalopathy. The beriberi and the Wernicke's encephalopathy. The common cause for deficiency of thiamine, we had seen previously also, is a chronic alcoholism. Two reasons in chronic alcoholism: the dietary intake is poor. In addition, the thiamine absorption is inhibited by alcohol. So in chronic alcoholics, thiamine deficiency is likely to be there. Let's look at the two disorders one by one, starting with the beriberi. So beriberi can be of two types. First is the dry beriberi. The dry beriberi involves the CNS in the form of paresthesia, general weakness, atrophy, foot and wrist drop. The drops are characteristic. The foot and wrist drop in dry beriberi. Please note, when we say dry beriberi, it is involving the CNS. So dry beriberi is the name for cluster of CNS symptoms. It is the name for cluster of CNS symptoms. And then we have what is known as the wet beriberi. Wet beriberi is named for the cluster of symptoms of the CVS. One of the most characteristic findings is the high output cardiac failure. Other findings include palpitation, the tachycardia, aortic regurgitation, and edema in the limbs. Please note that although we have described the dry beriberi and wet beriberi involving the CNS and the CVS, it does not mean that if you have the symptoms of the dry beriberi, the symptoms of the wet beriberi may not be there. It is not necessary. They can occur simultaneously. The symptoms of dry and wet beriberi may occur simultaneously. All right, so they may occur simultaneously, so you have to keep that in mind. In addition, we see a variant of beriberi in the infants, which we call the infantile or the acute beriberi. This will be seen only when the mother's milk is deficient in B1. It will occur when the mother herself is a chronic alcoholic and she has a vitamin B1 deficiency. In that case, the vitamin B1 cannot appear in the milk because the mother is deficient. She cannot pass on the vitamin B1. So this was the beriberi. The second is the Wernicke's encephalopathy. So let's go to the Wernicke's encephalopathy. Again, it will be seen in the chronic alcoholics, and the characteristic findings are global confusion and ophthalmoplegia. The characteristic findings are global confusion and ophthalmoplegia. Sometimes the Wernicke encephalopathy can be complicated with the psychosis, and the condition is known as Wernicke-Korsakoff psychosis. The condition will be named as Wernicke-Korsakoff psychosis. The Now we come to vitamin B2. A quick recap of vitamin B1. RDA we said for B1 as well as riboflavin 0.5 milligram per 1000 kilocalorie of energy intake. The thiamine deficiency can be monitored by the erythrocyte transketolase activity measurement. The functions, it is a part of the pyruvate dehydrogenase, the alpha ketoglutarate dehydrogenase, the transketolase, the branch chain ketoside dehydrogenase. It is also required for the acetylcholine formation, and it helps to regulate the chloride channel conduction. It is very important for energy metabolism. Deficiency results in the beriberi and the Wernicke encephalopathy. In beriberi, we have the dry beriberi and we have the wet beriberi. Dry beriberi involves the CNS. The wet beriberi involves the CVS. Characteristic finding in dry beriberi will be the foot and the wrist drop. In the wet beriberi, it will be the high output cardiac failure. In addition, we have what is known as the infantile beriberi. It is seen in those infants where the mother herself is deficient in vitamin B1. And then we have the Wernicke's encephalopathy, again seen in chronic alcoholics. One of the important findings are the global confusion and ophthalmoplegia. And if psychosis is present, we call the condition as Wernicke-Korsakoff psychosis. We call the condition as Wernicke-Korsakoff psychosis. So that's vitamin B1. Let's move on to vitamin B2. Please note, vitamin B1 is very commonly coming in your exam as the clinical case. In the last 4-5 years, we have seen this question coming at least 4 times, either as a straight line question or as a clinical case. The whole presentation is there, that what is the uh, position of the person, whether he is living alone, what type of food he is eating, and then the presentations of the either wet very where they'll describe the high output cardiac failure, the edema in the limbs can be mentioned. So all that can be mentioned, and they may even describe the enzyme activity to help you narrow down the diagnosis. We come to riboflavin, that is vitamin B2. Riboflavin is a part of flavin containing enzymes. So you see there are large number of enzymes which require the riboflavin. Wherever you make use of the FAD, it implies you are making use of the riboflavin. So wherever we have the use of the FAD or FADH2, we are making use of the riboflavin. Okay, large number of enzymes are there. For example, the succinate dehydrogenase. For example, in beta oxidation, we had seen and the FADH2 is required. RDA we had said previously, just like the thiamine, the RDA is 0.5 milligram per 1000 kilocalorie of energy intake. Alright, so this also has a very important role in energy metabolism. The main dietary source of riboflavin are milk and dairy products. And deficiency is identified by activity of erythrocyte glutathione reductase. So for B1 it is a transketolase, and for B2 it is the glutathione reductase. Again I'll say the riboflavin deficiency is also being asked commonly as a clinical case. Deficiency of vitamin B1, B2 and B3. These three are commonly asked as clinical case in exam. In the last 4-5 years, we have seen at least one of them will always be there in your paper. Sometimes B1 and B2 both can be there in your paper. So riboflavin deficiency is known as the riboflavinosis. The deficiency is known as riboflavinosis. All right. The primary finding is stomatitis. The primary finding is stomatitis. This stomatitis is similar to what we'll see in the pellagra, that is vitamin B3 deficiency. So what is the presentation? Painful red tongue with sore throat. This painful red tongue in some older books you'll find is written as beefy tongue. Painful red tongue with sore throat, that is the beefy tongue. Chapped and fissured lips known as chelosis. The chapped and fissured lips known as chelosis. The inflammation of corners of mouth known as angular stomatitis. See, all of this will occur if there is stress. In stress, the consumption of vitamins increases, and if there is a borderline case, there the deficiency will be quickly precipitated. For example, when you're preparing for the exam, suddenly lockdown is there and your father has been unable to send you the pocket money. Lockdown is there and you're not able to meet your girlfriend or boyfriend, so that time there's a lot of stress, and this angular stomatitis can appear in those scenarios. Okay. In addition, we have the anemia. The anemia is described as normocytic normochromic. See, NCNC anemia. The description is NCNC anemia. In addition, the seborrheic dermatitis is seen. Because the stomatitis that is seen here is also seen in pellagra. At first look, you may confuse it with pellagra, and the deficiency sometimes is known as pellagra sine pellagra, means looks like pellagra but it is not pellagra. Deficiency is sometimes known as pellagra sine pellagra. Okay. So that was vitamin B2. Remember, B1 and B2 deficiency are being commonly asked as a clinical case. I'll very quickly go through the riboflavin, that is B2 again. Flavin containing enzymes or the flavor proteins require the riboflavin, meaning anywhere you require the FAD or FADH2, we are making use of the vitamin B2, that is riboflavin. RDA, just like the vitamin B1, is 0.5 milligram per 1000 kilocalorie of energy intake. Therefore, it is another vitamin involved in the energy metabolism. The main dietary source of the riboflavin are milk and dairy products, and the deficiency can be monitored by measuring the activity of erythrocyte glutathione reductase. Riboflavin deficiency is known as ariboflavinosis, which results primarily in the stomatitis. It results primarily in stomatitis. The findings include the painful red tongue with sore throat, the chapped and fissured lips, that is chelosis, inflammation of the corners of mouth, that is angular stomatitis, and the normochromic normocytic anemia. In addition, the seborrheic dermatitis may be seen. Because the stomatitis is similar to that of pellagra, it has also been called as pellagra sine pellagra. Looks like pellagra, but it is not pellagra. And then we come to niacin. Niacin is vitamin B3. The biological activity of niacin is present in the nicotinic acid and the nicotinamide. The nicotinic acid and the nicotinamide. The functional forms of vitamin B3 are NAD and NADP. We have seen the NADH and the NADPH. NAD is also the source for the covalent modification of protein, that is the ADP ribosylation. NAD is the source for the ADP ribosylation. It also has an important role in intracellular calcium regulation and cell signaling. It has important role in intracellular calcium regulation and cell signaling. We already said 60 milligram of tryptophan can be converted to 1 milligram of niacin in the body. Niacin is one of the two vitamins synthesized by the body. First was vitamin D and second is the vitamin B3, that is niacin. It is synthesized by the body. So like I said, the 60 milligram of tryptophan is converted to 1 milligram of niacin. Please note that excess of niacin can also cause toxicity because its effect is long lasting. It can cause dilatation of blood vessels and flushing along with skin irritation. It causes liver damage, and it can cause macular edema and macular cyst at supraphysiological doses. At supraphysiological doses, it can cause macular edema and macular cyst. Now, more commonly, the white toxicity is seen rarely. More commonly, what we see is the vitamin B3 deficiency, that is pellagra. Characteristic of pellagra is the 3Ds. The 3Ds means diarrhea, dermatitis, and dementia. The type of dementia is the depressive psychosis. In addition to this, like I mentioned, we have the stomatitis. We have the glossitis and the stomatitis, in addition to the diarrhea, dementia, and dermatitis. If untreated, the various Ds will fuse together to form the big D, that is death. If untreated, we get the fourth D, that is death. A very characteristic finding in these individuals is the Casal collar or the Casal necklace. Scaly pigmentation is seen in the neck in severe case of pellagra along the dermatome C3 and C4. Just 2 years back, last year in fact, we had this question where they had given the image of the Casal collar, and you were asked 25 in which amino acid deficiency we are likely to get this appearance of the Casal collar. Classically, the pellagra has been common in maize or sorghum eaters. Reason being, the leucine, which is present in large amount in these foods, can interfere with the conversion of the tryptophan to niacin. In addition, these substances are also poor in the tryptophan content. So, leucine content interferes with the conversion, and tryptophan content is low. More recently, we find the deficiency to appear in the Hartnupp's disease and in the carcinoid syndrome. We had seen in the Hartnupp's disease there is loss of the tryptophan, therefore, sufficient tryptophan is not available for conversion into the niacin. In carcinoid syndrome, the tryptophan is diverted towards the synthesis of the intermediates. The 5-hydroxytryptamine is required, is synthesized from the tryptophan. So in both these two conditions, there is a gross deficiency of the tryptophan. When tryptophan is not there, sufficient amount of niacin cannot be formed. Nowadays, the population consuming exclusively maize or sorghum is somewhat rare. So more commonly, you will find pellagra in patients of Hartnupp's disease and carcinoid syndrome. So if you see the Casal collar, Casal necklace, you take the history and you're not finding any dietary deficiency or excess consumption of maize or sorghum like that, then you should start suspecting either the Hartnup disease or the carcinoid syndrome. And then we come to vitamin B5. Let's quickly take a look at the B3. I'll revise it very quickly. B3, the biological activity is present in the nicotinic acid and nicotinamide. The functional form are NAD and NADP. NAD is also the source for the covalent modification of proteins, that is the ADP ribosylation. It has a role in intracellular calcium regulation and cell signaling. 60 milligram of tryptophan can be converted to 1 milligram of niacin in the body. Niacin is one of the few vitamins which are water soluble, and still they can be toxic at high doses. It causes dilatation of blood vessel and flushing. In addition to the skin irritation, it can cause liver damage, and at supraphysiological doses, it can cause macular edema and the macular cyst. It can cause the macular edema and the macular cyst. More commonly, what we see is the pellagra. Pellagra presents with the 3Ds: the diarrhea, dementia, which is the depressive psychosis, and the dermatitis. It is a photosensitive type of dermatitis. In addition, we had mentioned there is the stomatitis. We find the glossitis and the stomatitis. If you don't treat these patients, all of these complications will result in the death of the patient, which is also known as the fourth D of pellagra. A classical finding is the Casal collar or necklace, which is the scaly pigmented rash around the dermatome C3, C4. Okay. More commonly in the past, it has been seen in maize or sorghum eaters in which the leucine content is high and the tryptophan content is low. Leucine interferes with the conversion of tryptophan to niacin. In addition, there are other factors which will affect this conversion. We'll see them later. The Hartnup disease results in tryptophan deficiency. So again, pellagra can be there. Carcinoid syndrome also consumes large amount of tryptophan. So here also the pellagra may be seen. Moving on to vitamin B5, that is the pantothenic acid. It is the part of acyl carrier protein in fatty acid synthesis, and it is required for the synthesis of coenzyme A. Pantothenic acid is required for the synthesis of coenzyme A. The coenzyme A is used in the following reactions in the citric acid cycle. First, for the formation of the acetyl coenzyme A, and later on for the formation of the succinyl coenzyme A. Strictly speaking, only succinyl coenzyme A, because formation of acetyl coenzyme A is actually the link reaction. Then in fatty acid oxidation to form again the acetyl coenzyme A, various acetylations, and in the cholesterol synthesis where we get the intermediate HMG CoA. Okay, hydroxymethyl coenzyme A, that is an intermediate where we are making use of the CoA. So pantothenic acid forms the coenzyme A, which is useful in a large number of reactions. Just like vitamin E, the deficiency of the B5 is unknown. In the past it has been attributed to cause the nutritional melalgia, also known as burning foot syndrome. But in the later research, when we've done the detailed research, it has not been found to be true. This burning foot syndrome is not actually due to the B5 deficiency. However, in the past, it was ascribed to the vitamin B5 deficiency, no longer accepted. This concept is no longer accepted. So pantothenic acid will form the acyl carrier protein and the coenzyme A. Vitamin B6, very important, pyridoxal. The active form is pyridoxal phosphate. The various structures which are active: pyridoxine, pyridoxal, pyridoxamine, along with their phosphates. Therefore, we have six different forms which show the biological activity: pyridoxine, pyridoxal, and pyridoxamine. The most active coenzyme form is the pyridoxal phosphate. We'll see it is required in large number of reactions. It is the most important function as coenzyme for glycogen phosphorylase. We had seen this where it is acting as the donor of phosphate. The phosphate will be used to cleave the last glucose, and it is released as the glucose 1 phosphate. Deficiency status is identified by measuring the erythrocyte transaminase. For transamination also we require the pyridoxal phosphate. So one, we talked about the transketolase. The transketolase was for B1. Then we talked about the glutathione reductase. Glutathione reductase was for vitamin B2. And now we are talking about the erythrocyte transaminases, and this is for vitamin B6. So these are some of the erythrocytic enzymes which can be used to monitor the vitamin deficiency. The erythrocyte transketolase monitors the vitamin B1 deficiency. The erythrocyte glutathione reductase monitors the vitamin B2 deficiency, and the erythrocyte transaminases are used to monitor the vitamin B6 deficiency. The pyridoxal phosphate is required as the coenzyme or cofactor in a very large number of reactions which are very frequently asked in your exam. Let's quickly take a look at which process will require the pyridoxal phosphate. Broadly speaking, it is required for the transamination, deamination, and decarboxylation. That is why we had used the enzyme transaminase to determine the concentration of vitamin B6. Some specific examples include the synthesis of catecholamine, the serotonin, and GABA, the synthesis of serine, the enzyme serine racemase, the metabolism of methionine and cysteine. Both of them are sulfur containing amino acids. In their breakdown, we have two common enzymes, the cystathionine synthase and cystathionase. Both of them require the pyridoxal phosphate. In the synthesis of selenocysteine, in the synthesis of selenocysteine, we require the pyridoxal phosphate. Then from conversion of tryptophan to niacin, meaning if vitamin B6 is deficient, then also we can get the pellagra. If vitamin B6 deficiency is there, then also we can get the pellagra. We already seen that is required for glycogenolysis by the enzyme glycogen phosphorylase. It is required in the synthesis of sphingolipids, and we had seen in heme synthesis it is required. The paradoxal phosphate is required for activating the glycine in first step in heme synthesis. So these are some of the very important biochemical reactions where vitamin B6 is utilized. We'll quickly do a recap for vitamin B6. Okay, B6 activity shown by the pyridoxal, pyridoxamine, and their phosphates, giving us a total of 6 active forms. The most active coenzyme form is the pyridoxal 5-phosphate, and the most important reaction where it is acting as the coenzyme is the glycogen phosphorylase enzyme, for the glycogen phosphorylase enzyme which cleaves the glycogen. Deficiency state is identified by measuring the erythrocyte transaminase activity. Various reactions where the pyridoxine is required in the form of pyridoxal phosphate include the transamination, deamination, decarboxylation. In the biosynthesis of catecholamine, serotonin, GABA. In metabolism, serine by the enzyme serine racemase. In the breakdown of methionine and cysteine by the enzyme cystothionine synthase and the cystathionase. In the biosynthesis of selenocysteine, in conversion of tryptophan to niacin, whereby it can also cause pellagra. In the glycogenolysis, in the sphingolipid formation, and in the heme synthesis. Pyridoxine deficiency can occur due to consumption of drugs. The most common cause in India is the isoniazid. So mostly the pyridoxine deficiency is drug induced. Mostly it is drug induced. In case of pyridoxine deficiency, what we find increased sensitivity to actions of low concentration of estrogen, androgen, cortisol, and vitamin D. In addition, we find abnormalities in the tryptophan and methionine metabolism. We had seen in tryptophan conversion to niacin and metabolism of methionine and cysteine. Also, we require the pyridoxal phosphate. Deficiency will classically present with peripheral neuropathy. Now, this is not a diagnostic feature because in pyridoxine toxicity also there is neuropathy. So the other features, the sideroblastic anemia and urinary findings of homocystinuria, oxaluria, xanthinuria become equally important in identifying pyridoxine deficiency. Please note, toxicity of pyridoxine also causes a neuropathy. Okay, so this is about the pyridoxine. One very important question which comes here, that in case of isoniazid, when there is pyridoxine deficiency, which group of individuals or which group of patients are more likely to present with pyridoxine deficiency? Your options are the slow acetylators or the fast acetylators. Out of the two groups, which individuals are more likely to present with pyridoxine deficiency when the isoniazid is being provided or it is being given for the treatment of the tuberculosis? I'm sure you know that isoniazid is the drug for tuberculosis, and because of the wide prevalence of tuberculosis in our country, it is very commonly consumed by large number of patients. And if supplementation with pyridoxine is not there, the deficiency is quite likely to occur. But in which group of individuals the deficiency will occur first, whether in the slow acetylators or in the fast acetylators? You have to tell me where the deficiency will occur first, in the slow acetylators or in the fast acetylators. Quickly tell me the answer, slow or fast, slow acetylators or the fast acetylators? No one wants to give the answer. Please note, the answer is not the fast acetylators. It is one of the most commonly wrong answer that we give. The answer is not the fast acetylator. Rather, it is the slow acetylators where we are more likely to see the pyridoxine deficiency. The reason is very straightforward. In metabolism of isoniazid, there is an intermediate. Very good, very good. There is an intermediate which has the potential to combine with pyridoxine. So if we have the fastest dilators of the intermediate has a short half-life, it cannot combine with the pyridoxine. But if we have the slow acetylators, the intermediate will have a longer half-life and therefore it gets time to combine with the pyridoxine, thereby causing pyridoxine deficiency. Testing the individual for slow and fast accelerator is not very cheap, so the cheaper option is give the supplementation of pyridoxine to all other individuals. Testing will be costlier than giving the supplementation of pyridoxine to all the individuals. So whenever we start an individual on treatment with isoniazid, we have to ensure that the drug regime also includes the supplementation with pyridoxine. It is included by default nowadays, so very unlikely that this mistake will happen. But you have to emphasize to the patient that the pyridoxine tablet has to be consumed without fail with the isoniazid tablet. Please note, we can't give a loading dose when we are starting the isoniazid. Why? Because the toxicity also causes neuropathy. So we cannot induce the toxicity because it will result in a neuropathy. We cannot give a loading dose to the patients in whom we are starting the isoniazid treatment. And then we come to biotin. Biotin is known as vitamin B7. Sometimes it is also known as the vitamin H. Sometimes it is also known as the vitamin H. Biotin is primarily required for the purpose of carboxylation. It is the most important coenzyme for carboxylation. Almost all carboxylation will require the biotin. So which are the carboxylases present in the human body where the biotin will be required? First, the acetyl coenzyme carboxylase. The acetyl coenzyme carboxylase will convert the acetyl coenzyme to malonyl coenzyme, which is the first step in the fatty acid synthesis. Then the pyruvate carboxylase, which converts the pyruvate to oxalate state in the gluconeogenesis. Then we have the propenyl coenzyme carboxylase. We had seen this. The propenyl coenzyme carboxylase converts the propenyl coenzyme in the methyl malonyl coenzyme. And then we have the methyl crotonil coenzyme carboxylase. Just remember this name. It is used in the metabolism of carbon skeleton of the amino acids. The methyl crotonil coenzyme carboxylase. Will not go into the details. I told you will not go into the metabolism of the carbon skeleton of the amino acids. So these are the four names. These are the four enzymes which are carrying out the carboxylation and require biotin for their optimal activity. So biotin plays a role in regulation of cell cycle also, and it is widely distributed in food. Therefore, dietary deficiency is unlikely. Only in the special cases the dietary deficiency can occur. For example, when a person starts consuming very large amount of egg white, or if the person is on prolonged parenteral nutrition where the biotin supplementation is not adequate. All right, so it is widely distributed in food. Dietary deficiency is unknown. This question where it results in deficiency when large amount of egg white is consumed has been asked multiple times. Please note, the egg white contains a substance called avidin. Egg white contains a substance called avidin. However, when you cook the egg, whether you are making the boiled egg, or you're making a poach, or you're making a full fry, where you're making an omelette, you're making a scrambled egg, when you heat the egg, the avidin gets destroyed. However, if you eat the raw egg, the avidin will be there and it will combine with biotin and prevent the absorption. Remember, biotin was one of those vitamins which was synthesized in the large intestine and also absorbed from the large intestine. Okay, so you need to consume very large amount of egg white before this avidin will be able to prevent the complete absorption of biotin, and typically we require a dozen egg being consumed regularly daily. So this is a somewhat a fad, or you can say the dietary practice in individuals who have recently started going to the gym or started doing the exercise as a source of protein. A lot of ad hoc gym trainers will tell them that you should eat the raw egg white. Raw egg white is a very good source of protein. You eat the raw egg white, and suddenly you will have a lot of good body mass. You don't need other protein supplementation. So a person who has recently started gym would get the advice from one of his trainers that you eat the raw egg white about 8 to 12 every day, and that is when the person will land up in the biotin deficiency. We will need to supplement the biotin in these individuals to immediately reactivate these enzymes, because in the absence of biotin these enzymes will not be working. A quick recap of the biotin. It is a coenzyme for the carboxylase enzymes, the acetyl coenzyme carboxylase, the pyruvate carboxylase, the propyl coenzyme carboxylase, and the methyl crotonal coenzyme carboxylase. It also plays a regulation in cell cycle. It is widely distributed in food, and dietary deficiency is unknown. It can occur in prolonged parenteral nutrition, the dietary deficiency, or it can occur with consumption of large amount of uncooked egg white in the range of about a dozen eggs. Reason being, the raw egg white will contain avidin. It binds to the biotin and prevent absorption both in the small intestine as well as in the large intestine. In both the places, it will prevent the absorption. Coming to the folic acid and the cobalamin, B9 and B12. Please note that the B9 and B12 are the vitamins of uh, the blood circulation of the RBC and WBC. So more details of the B9 and B12 will be covered in the hematology section in pathology, but I'll give a brief important biochemical overview of the B9 and the B12. The various forms of tetrahydrofolate are the active form of folic acid. Alright, so the various different names of tetrahydrofolate can be N5 formyl tetrahydrofolate, form amino tetrahydrofolate, methyl tetrahydrofolate, N10 formyl tetrahydrofolate. You can have the methylene tetrahydrofolate, or you can have the methinyl tetrahydrofolate. So all these prefixes can be used with a tetrahydrofolate representing the active form of the folic acid. Now there are two things here which you have to keep in mind. The serine is the most important source of the substituted folate, meaning the methyl group coming into the folate group. But the major point of entry for one carbon fragment is the methylene tetrahydrofolate. So you have to read the statement of the question carefully. What are they asking? Are they asking about the source, or are they asking about the point of entry? Okay. In addition, are they asking about the source of tetrahydrofolate for tissue? So these are three different questions. The important source of the methyl group, important source of methyl group is the serine. The point of entry is the methylene tetrahydrofolate. The major source of tetrahydrofolate is the methyl tetrahydrofolate. The methyl tetrahydrofolate is recycled to give us the tetrahydrofolate. So accordingly, you will read the question and then you will mark the answer, whether they are asking about the donor of the methyl group, they are asking about in what form it enters the metabolism, or from where the tetrahydrofolate is regenerated. So accordingly, the different answers will be there. The marker for folic acid deficiency is the FIGLU. It is an intermediate of histidine metabolism. So what we do, we give a loading dose of histidine, and then we measure the level of FIGLU in these patients. So what will happen, there will be FIGLU accumulation in these patients if the vitamin B9 is not there, or it is deficient in the individuals. In addition, deficiency during pregnancy predisposes to the meningomyelocele. predisposes to meningomyelocele. So if a female is planning a pregnancy or she has just become pregnant, it is advised that the B9 supplementation must be given to these females, particularly if the female are on the higher side of age group, maybe 32 plus or 35 plus, there will have more chances of these deficiencies. So supplementation of B9 before planning pregnancy or in the first trimester of pregnancy is advised to decrease the chances of the meningomyelocele, to decrease the chances of spinal cord disorders. Please note, the folic acid deficiency also causes the deficiency causes megaloblastic, it causes the megaloblastic anemia, it causes the megaloblastic anemia. Now there are various inhibitors of folate metabolism. We can use the inhibitors of folate metabolism in multiple ways. For example, the methotrexate is used for cancer chemotherapy. The trimethoprim, which is specific for the dihydrofolate reductase of the bacteria, is used as the antibacterial drug. Similarly, the pyrimethamine, which is specific for the enzyme in the malarial parasite, it is used as the anti-malarial drug. For the conversion of the methyl tetrahydrofolate to the tetrahydrofolate, which we had said was the primary source of the tetrahydrofolate, we require the B12. We require the B12. So what happens if there is B12 deficiency? The methyl tetrahydrofolate will remain as such, the tetrahydrofolate will not become available, and there will be functional folate deficiency. This is what is known as the folate trap. The folate trap question is very commonly asked, so you should remember the folate trap is blocking the tetrahydrofolate in the form of methyl THF. The conversion of methyl THF to THF requires the vitamin B12. If B12 is not there, then the methyl THF will exist and tetrahydrofolate will not be formed. This is known as the folate trap. What is the problem here? In folate trap, we find the megaloblastic anemia. We find the megaloblastic anemia, and sometimes without testing we can give the supplementation of the B9. In this case, the folate trap will be overcome, means extra B9 you have given, which will become available as the folate, and the requirement will be fulfilled. But please note, the B12 deficiency will be exaggerated. Whatever B12 is there will now start getting used for this recycling of the excess folate that you have provided, and the problem of B12 which relates to the neurological symptoms will be exaggerated. So please note, before giving the folic acid supplementation, you have to ensure that B12 deficiency is not there. If you are unable to ensure that B12 deficiency is there or not, then you must supplement with vitamin B12 also. So you have to choose one. Either you determine that B12 deficiency is not there, or if you cannot do that, then you add the B12 to the supplementation. Like I said, the folate deficiency causes the megaloblastic anemia. In addition, the folate supplementation can increase the risk of developing the colorectal cancer, but not in all people, only in those people who have the pre-existing pre-neoplastic colorectal polyps. Those individuals who have the pre-existing pre-neoplastic colorectal polyps, in those individuals if we give the folate supplementation, it is seen that there is increased risk of developing the colorectal cancer, increased risk of developing the colorectal cancer. So let's quickly do the recap for folic acid. The active forms are the various types of tetrahydrofolate. They can be the formyl, formimino, methyl group, methylene group, methinyl group. The formyl forms can be attached at N5 or they can be attached at the N10 form. The methyl group is obtained from serine. The first activated tetrahydrofolate is the methylene tetrahydrofolate. The tetrahydrofolate is commonly obtained by the recycling of the methyl tetrahydrofolate, by the recycling of the methyl tetrahydrofolate by B12, by B12. Figlu is the marker of intracellular level of folate. We give a loading dose of histidine and then measure the Figlu levels in the urine. If they are elevated, it indicates the deficiency of vitamin B9. The metabolism of Figlu requires the B9. Deficiency during pregnancy predisposes to meningomyelocele. Therefore, before planning pregnancy or in the first trimester of pregnancy, the B9 supplementation is advised in all individuals. Various drugs can inhibit the folate metabolism in different organisms. For example, in humans, the methotrexate will inhibit the folate metabolism. It is used for cancer chemotherapy. Trimethoprim inhibits the bacterial form of the dihydrofolate reductase. Therefore, it is used as the antibacterial drug. And paramethamine for the malarial parasite, the anti-malarial drug. Vitamin B12 deficiency, I told you, is causing the functional folate deficiency because it is required for conversion of methyl tetrahydrofolate to tetrahydrofolate. This is what is known as the folate trap. If you take high amount of the folic acid, then this B12 deficiency, which is causing the folate trap, may get masked. The megaloblastic anemia will recover, which is the characteristic finding of both the folate deficiency and the B12 deficiency. Folate supplementation in individuals with pre-neoplastic colorectal polyp has shown increased incidence of the colorectal cancer. So you have to be careful. You cannot blindly give the B9 supplementation to all the individuals, particularly who are more than 40 years of age. Lastly, we come to vitamin B12. B12, the cobalamin. There are two enzymes which require the B12. The methyl malonyl coenzyme A mutase, we had seen it converts the methyl malonyl coenzyme A to the succinyl coenzyme A. And the methionine synthase, we had seen this was the enzyme for the metabolism of sulfur containing amino acids. Okay, so methyl malonyl, where it is formed as an intermediate of catabolism of valine. It is formed by the carboxylation of propionyl coenzyme A. We had seen the propionyl coenzyme A can come from the odd number of fatty acid with odd number of carbon chain. It can come from catabolism of isoleucine. It can come from the catabolism of cholesterol. Lastly, it can directly come from propionate. These are the sources of methyl malonyl coenzyme A, which is acted upon by the mutase enzyme to convert it to the succinyl coenzyme A. We had seen this reaction when we are doing the metabolism of a fatty acid with odd number of carbon atoms. The B12 is found in food of only animal origin. So purely vegetarian individuals are likely to have the vitamin B12 deficiency. However, in the human population, in the Indian population, the B12 deficiency is rare in spite of the whole population being vegetarian. Why? Because none of the Indians are vegetarian. They consume milk is of animal origin, and strictly speaking they are not vegetarian, they are lacto vegetarian. They consume vegetarian diet along with milk. The milk is of animal origin and it is able to meet the requirement of vitamin B12. So vitamin B12 deficiency is rare in Indians because of large consumption of the milk. In Western population and the American population, where strictly vegan people are there the vitamin B12 deficiency can be seen. It is a result of the dietary fat where they are not consuming even a single type of animal product, and there we'll see the vitamin B12 deficiency. Importantly, vitamin B12 absorption requires two binding proteins. First is the cobalamin, which is being released in the enzyme in the stomach, the cobalamin, and second, the intrinsic factor. So the cobalamin will bind in the mouth, and it will protect from the digestive enzyme in the stomach, and later on the intrinsic factor coming from the stomach will bind to the B12 in the small intestine and get absorbed at the level of the ileum. Vitamin B12 is a cobalt containing vitamin. It is a cobalt containing vitamin. This question has been asked, which of the following vitamins is a cobalt containing vitamin? So the answer will be vitamin B12. Deficiency causes methylmalonic aciduria. We had mentioned this when we are doing the metabolism of short chain fatty acid, and we said that this methylmalonic aciduria is used as a means of assessing the B12 status. It is used as a means for assessing the B12 status. The B12 deficiency causes pernicious anemia. Okay, it causes the pernicious anemia. In pernicious anemia, a more common cause is the failure of the absorption of vitamin B12. The B12 absorption occurs only in the ileum, so because of multiple reasons there can be failure of absorption. Typically the dietary deficiency is not seen until unless you are following a dietary fad. So how can this failure in absorption occur? See, there are multiple ways. In the mouth, for example, suppose some individual is not producing secretion in the mouth, the covalophyllin is not there, so B12 will be degraded in the stomach. If there is atrophic gastritis, the intrinsic factor is not being produced, the B12 will not bind with the intrinsic factor, it cannot be absorbed in the ileum. Suppose a person has had an injury and his ileum has to be resected because of any reason, either due to injury or because of the bariatric surgery or something. So if the ileum is not there, again the B12 absorption cannot occur. So multiple ways in which the B12 absorption can be affected, and this is asked in the clinical scenario. A person had a road traffic accident where he had a penetrating abdominal injury. On the surgery table, the surgeon had to remove the ileum because of the gross rupture of the ileum. Subsequently, this individual during recovery developed the deficiency of one of the vitamins. Which vitamin is likely to be deficient? So in that case your answer will be vitamin B12. So multiple ways in which the failure in absorption of vitamin B12 can be there. So like I said, the deficiency causes pernicious anemia. It has two features. First, the megaloblastic anemia, which is similar to the deficiency in the B9. But second thing is the irreversible degeneration of the spinal cord due to failure of methylation of arginine residue in the myelin protein. In the myelin basic protein, we require the methylation of arginine, for which the B12 is required, for which the B12 is required. So when we're talking about the folate trap, we said when you give the large supplementation of the B9, the megaloblastic anemia will get corrected, but the irreversible degeneration of the spinal cord will get exaggerated because more of B12 will now be directed towards the recycling of whatever supplementation of the B9 you have given. A quick recap of B12. It is required. What is happening? Okay. Okay, quick recap of the B12. The methylmalonyl coenzyme mutase and the methionine synthase are the two enzymes which require vitamin B12. The methylmalonyl coenzyme, which is acted upon by the mutase, can be formed via multiple reactions. For example, it is an intermediate of catabolism of valine. It is produced by the carboxylation of propionyl coenzyme. The propionyl coenzyme itself is arising through the catabolism of isoleucine, the cholesterol, and the rare fatty acid with the odd number of carbon atoms. Lastly, it can directly come from a propionate. The vitamin B12 is found only in foods of animal origin. Vitamin B12 absorption requires two binding proteins, the cobalamin produced in the mouth and the intrinsic factor produced by the stomach. Cobalt is present in the vitamin B12. Deficiency of B12 causes methylmalonic aciduria, which is used as a means of assessing the B12 status. The most common cause of pernicious anemia is a failure of absorption, not the dietary deficiency, but the failure of absorption, which can occur at the multiple levels that we talked. If there is problem in the mouth, cobalamin is not being produced. If there is problem in the stomach, the intrinsic factor is not being produced. If the problem is in ileum, where the absorption has to occur. Deficiency causes pernicious anemia, which has two features: megaloblastic anemia and irreversible degeneration of the spinal cord, which is due to failure of methylation of arginine residue in the myelin basic protein. In the myelin basic protein. And last we come to vitamin C. Again, vitamin C will be discussed in great detail. Deficiency in pediatrics, because it causes the condition known as scurvy. But what are the biochemical aspects that you should know about? I'll quickly take a look at them. Vitamin C is a vitamin for only a few animals, for human beings and some of the other primates, along with guinea pig, bat, passeriform birds, fishes, and invertebrates. In other animals, it can be synthesized. In the organisms mentioned above, the enzyme L-gluconolactone oxidase is the only missing enzyme. All other enzymes of vitamin C biosynthetic pathway are present. Accidental deletion of the gene L-gluconolactone oxidase results in vitamin C becoming a vitamin in the above mentioned organisms. The ascorbic acid and dehydroascorbic acid both have the vitamin activity. The deficiency of vitamin C causes scurvy. It is one of the very important antioxidant. It is maintained in the reduced state by glutathione, and vitamin C also helps in the absorption of iron. It also helps in the absorption of iron. Important role of vitamin C. Vitamin C is having an important role. It is a coenzyme for copper containing hydroxylases and alpha ketoglutarate linked iron containing hydroxylases. For both these hydroxylases, it is working as the coenzyme. Which are these enzymes? The dopamine beta hydroxylase, copper containing. The peptidyl glycine hydroxylase, copper containing. The proline and lysine hydroxylase for collagen. The proline hydroxylase for osteocalcin, and the C1q component of complement, the aspartate beta hydroxylase for protein C synthesis, and the trimethyl lysine and gamma beta-betaine hydroxylase for synthesis of carnitine. For the synthesis of carnitine. So these are some of the enzymes for which vitamin C is required. The dopamine beta hydroxylase, peptidyl glycine hydroxylase, the proline and lysine hydroxylase, the proline hydroxylase for osteocalcin and C1q component, the aspartate beta hydroxylase for protein C, the trimethyl lysine and gamma butyrobetaine hydroxylase. Okay. So that will be all from the section of vitamins. Please note that vitamins is now a very important section for your exam. For example, in the last NEET exam, we had 8 questions coming from vitamin, 4 from the lipid soluble vitamins and 4 from the water soluble vitamins. So vitamins has become a very important focus for the examiners, and it is a very high topic. You can revise it quickly in 10-15 minutes, and you're likely to get up to 3 to 6 questions from this section of vitamins. So please don't forget to revise vitamins before you go for the exam. It is mostly revision based, very little to understand here. Mostly you have to quickly revise and keep in touch with the content of the vitamins. Tomorrow we'll have the session at same time 8 to 11, and tomorrow we'll start the molecular biology section. We'll need about 3 sessions to complete the molecular biology session. We'll see if it gets completed in 2, very good. If it doesn't get completed, then we'll extend it to 3. In the third session we'll also be talking a little bit about techniques of protein separation, the PCR, etc. So some techniques have to be discussed, we will do on the last day of the session. If there's some additional topics or points which you will want to have a look at, just let me know in the next 3 classes so that we can cover them in the last session. Anything you want to ask or any part you want me to repeat from today's class? If not, then we'll call it a day and close it for now. Any questions? Any questions you want to ask? Any questions that you want to ask? If there are no questions, then we'll call it a day. Okay, so if there are no questions, we'll